and what your projections are for next year?
We'll get that to you.
Thank you.
Thank you, Mr. Chairman. Thank you so much for the presentation. Can you speak a little bit more to the savings that you have managed to get from Kaiser and from your Medicaid Advantage and from your pharmacy benefits manager? How did you amass those savings? What are we doing differently?
When the procurements go out to be procured for these particular services, we actually project and expected what we expect the savings to be. And the way these savings were generated is that it was lower than what we anticipated our rates would be in terms of the procurements, and that's regarding Kaiser, the Medicare Advantage, as it relates to those particular vendors. And this actually the difference between what we expected and what the actual increase was.
So it was not a change in what you were asking them to do, not a change in the services?
Usually when we procure services, if there is a savings, it is either cheaper rates that they're offering us or something that's slightly different that would generate those savings. But we can get a little bit more specific once we get back to the office and provide you that information.
Thank you.
This refers to 17.6.1. That's the DISH funding. We're seeing a $23 million injection. Do you have a projection for the next few years, what we're looking at with DISH funding?
Usually when we look at, a DISH really hadn't swung that much in terms of what we have appropriated. It has been between 18 to 22 to $23 million. Right. And usually we have, you look at it over a year-by-year basis.
Right.
But we can look at it in terms of what we can estimate what a projected out cost would be in terms of DISH. The DISH that you see here is the DISH for private hospitals and not the IGT that's actually put out there for the public hospitals. Right.
So we're expecting to see this for the next 5 years or something like that? Do we know?
I would be guessing if I said yes,
okay.
But I would say for the past 3 years it has been 18, 22, and this year the recommendation is 23.
Okay. Okay. Thank you.
Commissioner, I've got a question for you. Given what's happening in Washington and really the uncertainty right now of some federal dollars that come to us to help you with your programs and all, could you sort of give us back of an envelope ideas about where we are and where we may be going and when if this continues, do we get negatively impacted with you able to do the things that you need to do in the Department of It? Would you speak to that, please?
Yes, sir. We met this morning and discussed our plans for the next several days and several weeks and then several months. We have enough funding for the CHIP program that will get us through March, through the end of March. So we're confident in that ability to be able to handle that situation. The bigger issue that we're currently faced with would be as it relates to some of our reviews and being able to respond to, in the HFRD, the Health Facilities Regulation Division, to respond to complaints that come up through some of our nursing homes. What the federal government, they came out with their guidelines last week, and they were in essence mirroring what they did the last time there was a shutdown with a few little tweaks. So there are certain activities that we will be unable to do, and they're very specific. The caveat to that, though, is any immediate jeopardy, referred to as an IJ, we do have the ability to address immediately. So we would be able to get out to those facilities where there was a potential for an IJ. Some of the recertifications and the new licensures, that's a concern to us. And it's something that we'll be speaking more with. Even though there's a, quote, shutdown, we do have contacts. We are in communication. Lisa was in communication with Washington earlier today, and Joe Hood and Melanie Simon are working cooperatively with them as well. And we'll know more. We're supposed to meet again on Wednesday. just to continue with our contingency plans. But that would be the only real area that there is a potential for some exposure. And again, it has to do with recertifications and licensures and even new certifications. But from a patient individual safety standpoint, we do have the ability to make certain that we can do those site visits to ensure the health and safety of the individuals that we serve and that our providers serve.
Great, thank you. I want to commend you and the department for the aggressive stance that y'all took dealing with complaints that had backlogged, and that was one of the problems we were having with some federal programs.
Yes,
you had to resolve those issues before we could move on with some other things, and y'all done a good job with that, and I want to thank you for that. Any other questions or comments from the committee? Anything else you need to tell us?
No, sir. We're available. Andrew and Lisa Marie will be over here throughout the session. Brandy is out on maternity leave, so if you need anything from us, you can always call me, but Andrew and Lisa Marie are over here pretty much every day. So thank you very, very much.
Great. Well, thank you, Commissioner, and at least we appreciate that, and we look forward to continuing to work with you on that. Thank you. Next, we're going to hear from the Department of Public Health, Dr. O'Neill.
Okay, they were supposed to. I set one up there.
Okay, thank you, Dr. Neal. You go right ahead when you're ready.
Mr. Chairman, members of the committee, thank you very much for this opportunity to present Public Health's request for the amended 2018. On the screen, you will see 5 different areas that are critically important to us, and I would point out that the first 3 are priorities that Dr. Brenda Fitzgerald had established when she was the commissioner, which are still extraordinarily important to us, and that we're struggling to see that that we do some really great work to move the needle on those programs. Obviously, last year we received the prescription drug monitoring program from the legislature. It was moved from GDNA to public health, and as of July 1 of this year, the move over was complete. Also, as of July 1, there was a requirement that pharmacists or dispensers across the state input data within a 24-hour period on the prescription of opioids so that could be part of the PDMP. As of January 1, there was a requirement that practitioners also have registered with the PDMP. We were a little bit disappointed that the numbers were not as high as we had hoped, but that's continuing to improve. And as of July 1 of 2018, there will be a requirement that practitioners, as they get to the point of care of a patient where they're likely to prescribe an opioid, that they look into the PDMP to see what the past history has been, excuse me, for that particular patient. So there's a lot of activity ongoing with that, and I can talk more about the finances in just a moment. Cardiac care is another thing that you and the legislature assigned to public health last year, and the assignment was basically to develop a cardiac care network similar to the trauma system, in fact, modeled on the trauma system for the state of Georgia. And I think we're making some really good progress that I'll talk about in just a moment on that as well. Our early brain development happened to be Dr. Fitzgerald's #1 overarching priority for public health. And I support that wholeheartedly. I think if there is anything that public health can do, it's not going to be immediate, but down the road, the one thing that we can do in public health that's going to impact the health of the state most of all is going to be what we achieve in terms of improving early brain development in infants and young children. So that's still a major priority for us. Maternal mortality is something that I'm ashamed to say Georgia has been worst in the country over a period of time. We're beginning to move the needle, and I'll talk a little bit more about that later on. There's some strategies in place that have already started the movement. They've been very successful in other states, and I think we're going to see dramatic change over the next 1 to 2 years in maternal mortality in Georgia. But where we are right now, where we've been even before right now, is something to be ashamed of, not proud of. The last thing is an academic health department, and that's one of what I've been calling an acceleration phase. When we have a new governor and new commissioners, what I want to pass on to the new commissioner is a concept of, okay, we put together what we think are the basic principles that Dr. Fitzgerald was so successful in implementing. We've tried to institutionalize those, but that doesn't mean that we fixed everything. We have a long way to go. And one of the most important ways that I think that we can continue to move forward once we become accredited at the state level, which is another one of our goals this year, is to become more heavily aligned with the academic institutions in our state, of which we already have a tremendous number of programs that are in alignment, but we think there can be a lot more. And I just came out of a meeting that Dr. Gary Nelson with Healthcare Georgia Foundation chaired with the deans of Emory, UGA, and also Georgia State Schools of Public Health to talk specifically about what an academic health department is going to look like and how we can all participate for this to be truly a win-win situation, which I predict that it will be. Those are the 5 primary initiatives, but obviously there are hundreds of others, but those are the ones that we want to focus on. In looking at the cardiac care situation in this past year, with the funding that we got last year, $106,800, I think, we were only able to hire a registrar for that system. And I don't know if you recall, but in the study committee that looked at this last year, basically a whole host of things were projected as to what the system would eventually look like, but it was said over and over again that this would happen as funds became available. There was no expectation that we would be able to achieve this in 1 year time. But I think we've come a long way just in 1 year with the registrar. That registrar, we're very fortunate to have an individual that I've known for 20 years. He was an educator in EMS for 18 years. He received an MPH, and he's just now finishing his doctorate in public health. He's absolutely brilliant. He's done a fantastic job of helping us begin to understand what we're going to need in the way of data gathering to evaluate how successful the system is that we basically are trying to structure. Essentially, there is a request for an increase of funds of $193,500. That will bring us a little bit over $300,000 for the rest of 2018, which will essentially, for the most part, fill out the positions that we need at the state level to begin moving on, hopefully, by later in 2018 to the designation process of level 1 and level 2 cardiac centers across the state. The House funds for a prescription drug monitoring program request that we have is $582,892. And I think that the bulk of that, the largest amount of that, about $300,000 of that, goes for the contract that we have with APRIS. That's our vendor for the PDMP. The rest of it is for personnel to essentially function in the prescription drug monitoring program. Currently, we have 1 person and 2 contractors, actually 1 contractor at the moment, who have been working on that. And I tell you, they have done a stellar job of moving the PDMP from GDNA to public health in this last year and to facilitating the movement of practitioners into the system. So I'm hopeful that we're going to see a lot of progress going down the road with this. The other question that I commonly get from a lot of folks, particularly in the practice community, is, well, you know, it's problematic for a practitioner who is seeing a patient using an electronic health record. They get to the point where they're about to prescribe medications, and they have to go into a separate system, a separate portal, to see the PDMP for that particular patient. That's very time-consuming, which Practitioners do not have that time. It's very time-consuming and troubling to have to do that. Many states have developed an interface between the PDMP system and the electronic health records for the practitioners in that state. And that's one of the goals that we hope to achieve moving forward. We're not asking for funding to do that right now, but hopefully in the near future we will be able to achieve that as well. On the early brain development, the one thing, we're not asking for any additional funds on this right now. We've got several programs in place. Probably the one that I'm most enthusiastic about is Talk With Me Baby. I think language nutrition in that very early first 24 months of life, maybe 36 months, is absolutely critical. The data is stellar in showing the difference in a child that has had that versus a child who has not. So I think all that we do, that we currently have underway, just needs to continue, needs to be amplified over time. And CDC, with Dr. Fitzgerald now as the head, is going to be pushing this from the national perspective. So I want to keep Georgia in the forefront because I think she did a fabulous job of getting us started. I think we already are a leader in the country in this, but I think we're going to be seen in even greater light as time passes. What we're asking to do or planning to do is to utilize $159,000 roughly in existing funds for telehealth infrastructure. That's one program, support coordinator position also that will move her for that, to provide behavioral health services to children under 21 who are diagnosed as autistic. In the previous presentation, you saw the request from DCH in terms of additional funding on this same idea. And I would mention that I don't think there has ever been a time that I'm aware of in Georgia, and this year will be my 50th year as a physician in Georgia. I don't think I've ever seen a time when the commissioners of the health entities, public health, community health, behavioral health, and human services have ever worked more closely together. And we've got, I think, I'm biased, I think the other commissioners are wonderful to work with. And I think that the state will benefit by the collaboration that has been occurring, will continue to occur. And I think there's even going to be some recommended legislation coming down this year for additional requirements in terms of that collaboration that needs to continue. So I'm really excited about that, and I think that it's a great thing for Georgia that we're seeing that. The state changes I'm not going to mention because virtually all the agencies have those same changes that are underway. And I've talked a little bit already about the prescription drug monitoring program. The one thing that I want to mention, though, is I think that it's critical that we have this. It's obvious that the prescription of opioids has been extraordinarily problematic in terms of developing addiction issues. But it's only a tiny piece of this whole puzzle of what we do. I'm very concerned that we not focus our scope entirely on just opioids. What we have seen happen in other states that have been very successful with their PDMPs, where they have cut down on prescriptions for opioids dramatically, is that there has been an uptake, serious uptake, in deaths from heroin. And whatever we do, we've got to be cautious that we don't have unintended consequences as we reduce opioids, that we turn around and have something even worse. In some states, the death rate has been 4-fold greater from heroin as it was from opioids. So we in public health are charged with working with many, many agencies and also private sector organizations to continue to develop a strategy, not a public health strategy, but a state strategy for how we deal with the opioid crisis, but I'd like to think we deal with the addiction crisis as a whole. And we're well on the way to putting together many, many groups that have had input in the early phases of developing that strategy. And I hope by probably mid-2018 that you will see a pretty mature version of what the Georgia strategy is going to look like. We have a federal grant to actually craft that strategy with input from all those entities that have a purpose in this. So we're very interested in doing that. Obviously, aside from PDMP, the other role that public health always has is prevention. So we've got to maintain a prevention, an education, a communication piece that will always be a role of public health, along with the other agencies. Many of our sister agencies, like DBHTD, have a much larger role than we do. but I think we have a critical role all working together. So I'm excited about what's coming down with this. I don't want anyone to think that the PDMP is the ultimate answer for the problem. It's just one tiny piece. Law enforcement has a tremendous role. Early development of the early brain in children has a tremendous role. Education in early school, not waiting until late in school, has a tremendous role. Certainly treatment and recovery, ongoing management of those folks that have become addicted is absolutely critical. And I would suggest that you will find very few families in the state of Georgia that have not already experienced addiction within the family in some form or fashion. So this is something that's terribly important for public health to participate in, but along with multiple other partners in the state. On the 2018 DPH budget, you will notice that the bulk of our funding is federal. And actually, in some years, it's been greater than 60%. But 60% of our budget basically comes from federal grants that we have responsibilities for. Much of that goes out to the districts. A very small part of that stays at the state level. Public health's real role is where we see in the local level folks actually taking care of patients. So this federal budget is not for state. It's primarily being funneled out to our districts through various manners that we have, and it includes many programs that are of primary importance to us. State general funds are about 37%, and we're very grateful for that. I cannot tell you how much I would like to express appreciation to the legislature for the many things that you've done to support the needs of public health over the years, and certainly have been, during the time that Dr. Fitzgerald was commissioner, extraordinarily supportive, and I would solicit your ongoing help as we continue to try to improve the health of Georgians. So thank you very much, and with that, I'll take questions.
We have a few questions for you. Let's see. Carolyn, you. Representative Hughley.
Thank you, Dr. Neal. One of the things you talked about was maternal mortality, but I didn't hear a lot about what we're going to do about it. Are we utilizing our medical schools or midwives, or what are we going to do to address
Our primary strategy, certainly we are doing a lot of cross-sector work in all spheres, including medical schools, but that's a very tiny part of it. Probably the area where we're going to be able to move the needle the most is in our birthing centers. And we're looking at what other states have done and made tremendous advances by providing guidance, essentially almost like standard, I wouldn't say orders, but recommendations for what to do with a mother who's giving birth and what do you do for the month afterwards. It's really the month afterwards that tends to create so many of our problems. And what we have been doing with our birthing centers is distributing these packets of guidance for what should happen, what the obstetrician needs to be involved with, and also the pediatrician who's going to manage that baby. And the opioid crisis comes into play here too, because some of those babies are going to show up positive. Neonatal abstinence syndrome is going to develop. So the relationship between the pediatrician who's managing that baby and the mother is really critical. The other area that's really important, and it plays into our cardiac system of development, so many of the deaths of our mothers are occurring within a month after birth, and many of those ladies are dying from cardiovascular disease. So we've got a lot of things under play right now. The needle's already beginning to move. Most of the work is with the birthing centers.
May I ask one other question? If you would, where are the birthing centers? Do we have them all over, or are they in South Georgia? And then
I don't remember the exact total, but it's 70-something birthing centers across the state of Georgia, and they are all over the state.
And the next question is on behalf of Representative Thomas, who I see in the audience, and her question is about midwifery. Where are we on that, and where do you see the future of that going in our state?
I don't know that I have a crystal ball for the future of it. I can tell you that midwifery right now plays a very important role, particularly in some parts of the state, more so than others. But the work of in midwives, basically, certified midwives, are advanced practice nurses. And I see the critical need for those folks to continue because we have shortages, particularly in rural Georgia, of obstetricians. And the utilization of certified midwives is absolutely critical to what we do, particularly in rural Georgia. Not limited to rural Georgia, but certainly there.
Thank you, Mr. Chairman.
Thank you, Mr. Chairman. Commissioner, thank you for all the work you do in helping prevent conditions. We know that some of the things that we see every day can be avoided by really early intervention. Several years ago, you set up the very first registry of indicating the number of maternal deaths. And is that an ongoing process? And what happens with the results of that report? I mean, how is it used? It's still being done by the OBGYN Society, or?
Yes and yes, it is ongoing, and the group that is particularly working on maternal mortality, and it's not just OBGYN folks, but it's multidisciplinary, is looking at that data on a regular basis, because that will be part of what we use as a metric to determine if we really are moving the needle with these strategies that we have put into place. So I think ongoing, having that registry is absolutely critical, and how we use it is to guide what we continue to do. We think that the strategies we are putting into place, based on what's happened in other states, are going to be effective, and we've already seen a little bit of movement of the needle. But obviously, the data is going to determine whether or not that's the right strategy or if there's something better out there. So looking at that data in an ongoing fashion is absolutely critical for us. The one thing that I think is so critical for public health is to be data-driven.
Thank you.
Representative Stevens, did you have a question? Nope. Representative Hawkins? Okay. I think.
Thank you. I want to go back to the PDMP. I've already registered and I've got my number, but when I look at this, and typically I don't write more than 3 days anyway, so I wouldn't have to check the register, but I'm trying to work out in my head how this is going to work for a prescriber, like an orthopedic surgeon who will be writing for a week. The way I read the bill and the way I understand is he's going to have to check the register before he writes a script for the patient or someone on his staff, which means that pretty much going to be he in the office, in the room, doing it, right?
Right.
How fast is this going to operate for him? Because now, I mean, I see the back of his head typing into the computer all the time.
Exactly. And that's one of my worries, and why I think that the next step is to develop that interface between the PDMP and the electronic health record, because
Right.
You asked for how long it takes. On average, probably it takes an additional 5 minutes to leave your medical record, go into the PDMP, then come back to your medical record, make a decision. That's, in my opinion, that's wasted time.
That's a long time.
And other states have been very effective in developing this interface so that as you're in the electronic health record and you're to the point of prescribing, on a part of your screen you can see that particular patient's entries in the PDMP. That would be so time-saving for the practitioner, and that's what I think we need to be working toward.
So when they bring that patient's name up, it automatically engages the PDMP?
In those
And so
states
it
that have
brings the
developed this.
window up?
Now, the other thing to recall is that right now we don't have the legal authority to share that data between the PDMP and the electronic health records. That's one of the changes that we're recommending in terms of legislative change in this next session. We do not have that authority. The other thing that's really bizarre, we can't share PDMP data with adjacent states. And
With
we've
who?
got major problems cross-border.
Oh, other states. You know, years ago when we looked at this, probably 10 years ago, they had real time. Some states had started that, and I know some of them have it now, and at that time it was $500,000 for us to do it. We said, well, we can't afford it. But, I mean, real time to me works a whole lot better. We write it, and the pharmacist, before they fill it, looks at it, and if the patient has a problem, or I seldom write more than 12, 16. If it's 46, I've had them call me and say, did you write 46? I've never seen that. So we catch them that way. Or I've got a pad here. It doesn't look like your handwriting, a copied pad. You know, that was a safeguard. It seems logical. Is that something we can move to in
Yes.
the future, you think?
Absolutely, and I don't know if you recall, but that was one of the things that Dr. Fitzgerald had pushed heavily for. She wanted real time. It is going to be expensive, and I think we can work toward it. We will work toward it. But even if we can get to maximizing, once we change the law so that we can exchange this data, if we can do that in a real-time basis, I think, and with pharmacists inputting their information within a 24-hour period of time, I think that's a tremendous improvement over where we've been. Right. It's not ideal yet, right. And working toward real time, I think, is a laudable goal, and we need to be working toward that. But again, the cost is going to be something that we have to take into consideration.
Well, on this cost, you have total implementation cost. Next year, it looks like we're still going to be hiring the personnel, right?
Right.
And this says registry contract, so I assume we're still going to pay another $300,000. It's contract.
That's
right?
correct.
So we're going to see a revolving door of this charge again each year, right?
Yes, for those figures.
Good thing we're making more money. Second question, Crab A. Where are we on Crab A? You know, that's the legislation we passed last year, where they put the, you know about that?
You weren't
tell me where
screening.
we are? Yeah.
I'll have to check and let you know later on that. I know that Dr. Franco at our state lab has been working on that, and my understanding, the last that I had conversation with her, is that that is going to be contracted out. Is it through Emory? I think it is through Emory.
Okay. Because we had, that was the bill that I carried, we had New York said they would do it for, believe it or not, $3 to $5. I still have the email from Dr. Kurtzberg at Duke. Whatever it is, I just wanted, obviously it's got to be a fresh sample. There's some, you know, barriers there. But I'm hearing from families, and they're saying it's a year later and we still don't have it. So I appreciate speedy resolve.
We'll let you know. I'm pretty sure that if they have not yet started it, that it's imminent.
Right.
The other issue, I think, though, is going to be the piece that allows the family to decide if they wish to request it.
Right. We were going to put that in the brochure, give that to the mother, expectant mother. They would be responsible for the payment. Yeah.
Yep.
Right. Okay. Great. Appreciate the information coming forward. Thank you. That's it.
Thank you, Mr. Chairman and Dr. Neal. This is on behalf of Representative Cannon, and I hope I get her question right. In Indiana, in 2015, the governor declared that there was an opioid and HIV state of emergency. Are we seeing any connections between opioid use and HIV or other comorbidities here in Georgia from your evaluation?
At the present time, I don't have any data to show that there has been a connection there, but I can tell you one of the things that keeps me awake at night is trying to figure out why that's not already happened, because we've got a significant intravenous drug usage problem in Georgia, and why we've not seen either HIV or hepatitis C related to that in certain areas, I don't yet know. We are monitoring. We've got, I think, 4 counties, particularly in the northern part of the state, that CDC has identified as high risk for that developing. And we are very concerned to monitor the statistics very closely. And I think that as there may even be recommendations coming forward to the legislature later this year that would address some of the changes that CDC has recommended relating to IV drug use.
Would you get back to us and let us know what the plan is going to be when
Sure.
you develop it? Thank you.
Dr. O'Neill, let me ask you this question that I had asked others. With the uncertainty right now in the funding in Washington, and I understand they're trying to reach some agreement today, and hopefully that'll happen, but a large percentage of your budget is federal pass-through money, if you would. Can you sort of give us a little update or expound on that just a bit about where we are and if that's affecting you now or when, if that may become a problem for us, please?
Mr. Chairman, I think that's really a critical question for all of us. Right now in public health, I believe that we probably will not see any significant impact for about 2 or 3 more days. And after that, the impact will be there. And the areas that worry me the most, HIV, which is largely federally funded, and where we've got one of the highest rates in the country of new cases of HIV disease. To not be able to continue to work on that is going to be potentially catastrophic. The WIC program, Women, Infants, Children, the possibility of loss of that nutrition for our babies is extraordinarily worrisome. So those are major concerns. I also am very concerned about emergency preparedness. You know, we're having a horrible flu year, and who knows what the next outbreak is going to be. You know, we've seen Ebola, we've seen Lassa fever. Who knows what's going to be new on the horizon that we have to face? And CDC has already furloughed, I think, over 60% of their staff that are responsible for monitoring some of those things. So I'm quite nervous about emergency preparedness as well as WIC, as well as HIV. There are other programs, too, that are going to be affected. But those are the three that worry me the most.
Okay, thank you. Are there any other questions from the committee? Well, Dr. Neal, thank you to you and your staff for coming and being with us today and making your presentation. Also, our thanks to Commissioner Berry and his staff, and to the members of the committee for being here, and to those of you in the audience who have an interest in what's going on in healthcare. We thank you for being here today, and we'll adjourn the meeting at this time. Thank you.
Thank you, Mr. Chairman.